Doctors Baughman and Ludwick.
Thank you. Glad to be here. Good to see so many familiar faces. A lot of these folks didn't say it in our bio backgrounds, but we've connected with the people from SUMA, and our original work began, and Kris and I got to know each other from our original work in SUMA, and you'll hear about that from Kris in just a little bit. I think the other thing that you need to know is that I've done this project, our advanced care planning, from the trenches. I'm a registered nurse and have done this with students, with patients, and of course with family and friends innumerable times. So I think that's why you'll hear me as we talk. I'm going to emphasize the first half of the content for these objectives. Kris is going to talk about the latter. So I'll talk about the need for advanced care planning and do some comparing and contrasting of terms. And Kris is going to focus on advanced care planning resources. And I hope then that our goal here is to keep it simple and lay the groundwork for you, Patty, as you talk about your experiences and your case study. At any point, please feel free at the bottom to use reactions. We've got a lot of people, and I see not everybody has pictures up, so I can't just have you raise your hand literally. So, you know, do a reaction if you can, or use the chat. We won't spend a lot of time on discussion because I think that'll come with Patty's work. But at any point, you can feel free to give us a high sign as to what your role in advanced care planning is. So with that in mind, let me talk about advanced care planning in general. 70, if not 80% of people identify that they want to die at home. And I'm sure if we ask each of you, many of you would probably have a similar wish. But a little more than 1 in 4 of us have any type of written document. And those that don't do it, what do they tell you? I just haven't gotten to it. How many of you have heard that? My experience has been, I hear it a lot, and I'm quite sure that you do as well. In fact, Bob Dyer, author and journalist for the Beacon Journal, recently in the last 6 months before he retired from his position, said one of his big accomplishments was getting his advanced directives done. And when he said why he hadn't done it, I just hadn't gotten to it. So it's common, not unheard of. One thing that's important to note is that we age, we do increase participation. But even given that, only 22% of those age 65 have ever participated in a conversation with a healthcare provider about advanced care planning. And ACP rates also vary among race and ethnic backgrounds. So for example, Blacks and Latinos have a relatively lower rate of ACP involvement than the white population. And also other factors like big concern of mine or big issue for me is health literacy. And health literacy can be tied to financial stability, but not only that. I never believe that just because you have an education means you understand what's going on related to health literacy. And I'm sure many of you who I've worked with and who I know of would feel the same way. The resources for this were found at Kaiser. This is, if you don't know about Kaiser, Kris will talk about more, but we've interspersed some of our resources throughout the conversation. So Kris and I were kind of hoping that if you would put in the chat column whether you have, first just let us know with a raise of hand or a reaction if you've had conversations, so we get a kind of idea how many of you have been having conversations about advanced care planning, and also then with whom, if you could put some of that information in the chat box, if not by raising your hand, we'd appreciate it. So the next thing that I'd like to talk about is generally a little bit more about what we mean about advanced care planning. Kris and I have been working on this since 2009, and I remember Sue and Denise and, oh my God, Margie, we've been dealing with some of these issues forever. And at the time, we didn't have a really good definition of advanced care planning. And oftentimes it was meant to be only advanced directives, which is what the 1990 federal regs were about, which we'll talk about in a minute. But I like this definition, and I think it's getting real good root hold in the literature. Advanced care planning is a process that supports adults, and this is important, at any age or stage of health in understanding and sharing the personal goals, values, preferences regarding medical care. And the goal is to advance ensure that people receive medical care that is consistent with their values, goals, and preferences during serious and chronic illnesses. So when I taught nursing, even beginning nurses on death and dying, one of the conversations, talk about timing, was right before Thanksgiving. I told them to go home while everybody had a few drinks and start talking about advanced care planning. I asked my son to do advanced care planning before he was out of high school, and he did. One of the things he noticed was not his advanced directive about what he didn't want done, but also what type of music, if he was in an unresponsive state, he wanted to have played. I'd like to point out there was some good rock and roll in there too. But anyhow, the advanced directives themselves are a subset of that advanced care planning, and they include 2 legal documents. And I emphasize legal because sometimes this is where things get a little messy. Advanced care planning, advanced directives in particular, live in the world of legal and medical, as well as cultural and all those kind of things. They live in legal and the medical world at the same time. Living wills are the direction for future medical care. And often we talk about the do nots, and you're going to hear me talk about those more. Do not resuscitate, do not hospitalize, do not tube feed, and do not ventilate are the most common. The second is the durable power of attorney, which is the legal document for assigning someone else to be involved with your making decisions for you if you could not. And I'm scanning quickly. I see that a lot of people have family listed down as advanced care planning. And we found that with other healthcare providers too. So I'm hoping that just what I bring to you, it really doesn't matter. And I like this comment here by Eric. My wife and I have ours in place, but more importantly, we've discussed the need with our children and to have their children over 18 to have them completed. So I'm delighted to see that. It's been one of my big bugaboos and a big policy project that I'm pushing, which you'll hear about a little bit later. So in Ohio, though, what's important beyond that last slide where I talked about the definition by SEDOR in 2017 is this, in Ohio, it's the Ohio Administrative Code that handles, that's the legality for this. And we have 2 advanced directives in Ohio, the DNR comfort care arrest, and then the second one is DNR comfort care. And it allows in the second one what providers will do and will not do. And I will talk about that in the next slide. But before I move there, I want to give you these 2 links. One, it takes you to the form that I'm going to refer to. And the second is for providers like yourselves. And then the other one is, if you look at it, will give you a parallel one for the public to talk about what resources you can give to your public, patients and family. So this is a kind of a quick synopsis of the form. The form can be filled out by or witnessed by a physician, an advanced practice nurse, physician assistant. But there is, as you see, the 2 check boxes up there, that there is a DNR comfort care arrest. That means that I've highlighted arrest in red, that until you arrest, everything's the same. Then when you've had an arrest, respiratory or cardiac, then the comfort care protocol be implemented. And then DNR comfort care, which is the second way you can mark your preferences, is that you would have providers will do certain things and certain things providers will not do. Let me take a look at first the provider's will. You'll see that there doesn't mean you're abandoned. Frequently people think that that means, well, they're not going to take care of my pain. And I emphasize with people, if you've got an infection, and that seems to be a reasonable thing to take care of, they treat your infection. It's symptoms by what that you want to have handled. It doesn't mean hands off, we're not touching, we're not seeing you, we're not doing anything for you. But it does mean you try to protect patients and keep them safe and keep them symptom-free, but not prolong life or to prolong the death experience for that matter. But it does say what you will not do. And in the next slide, I want to emphasize that we talk about do nots, but that state law talks about will nots. So you can see how right away for the patients and public, why our roles are so very vital, because the terminology is, we say DNH and they go, huh? Now, most people recognize DNR, and of course, most people think DNR is pretty darn effective based on every TV show in America. And I will tell you another time, another place, DNR can be effective even in places where you wouldn't expect it, but it's not something to hang your hat on. So the will nots are the legal terminology. The do nots we frequently talk about. So I think it's important to just differentiate those. Okay, going on to the next slide. The other layer, we have advanced care planning. We've talked about advanced directives. The next layer is MOLST and POLST. These are in some states other than Ohio. So some states have either, they call them MOLST or POLST. POLST, physician, MOLST, medical. And they are just same as our form, but they're transportable across settings. So if now you fill out you fill out your setting for your wishes, you need to make sure you have it with you, and you need to make sure people see it. It isn't entered into a system that people already know it just automatically. They may ask you to fill out another one when you go to skilled nursing, or they may ask you to fill out again. We have a living will. My husband went into palliative care, and when he went into palliative care, then we filled out the do not comfort, the DN comfort care, do not resuscitate and comfort care orders. So there are these levels that go on. And there is a site here to learn more about MOLST and POLST. But these are all handled, the message here is these are handled state by state. That's important when you're dealing with, as many you've identified, parents or children. They may be out of state and have different rules. We certainly live in a state where we're close to other states, so it's important to know what's going on in the states around us. Then that leads us to where we've come since 1990. Originally, this work came from the 1990s, the Federal Patient Self-Determination Act, developed for Medicare facilities. And this is what most people know, but it's become the most routine thing in the world and the most often ignored thing in the world. And it's often when people say, just haven't got to it, or no, I didn't bring it with me. So I would ask you to think, are you in a position where you're handling these mandates? You could put mandates yes, mandates no. And how does your agency handle them? You can make a little comment about that. And perhaps the other part of it is, how do you respond when asked for yourself? Now, this isn't for a family member, but you yourself, have you done that? So I will turn this over to Kris, who's going to talk about our work in terms of resources for you, and then some of our policy and advocacy and research work.
Yeah. So what we know is that talking helps. The ACP conversations, advanced care planning conversations, often don't take place because patients are waiting for their physician to bring it up, or their other healthcare providers to bring it up, and the healthcare providers are waiting for the patient to bring it up. And so the conversation never really gets started. And same way with family members. You may be waiting for your parents to bring up the topic, and they may be waiting for you to bring it up. We know that when people do have those conversations, that it can take some of that burden away. People are less confused when they're trying to make decisions. When someone can't make those decisions for themselves, they feel less guilty, less anxiety, and less fear. So I want to give you a couple examples of some successful programs that have taken place. The first one is respecting choices. This one was done back in 1991 in La Crosse, Wisconsin through Gunderson Health System. And they had, and it worked well in La Crosse because there was only one healthcare system, so they could reach out to all of their providers. And what they did was they trained facilitators to go out and speak to people in the community and go through the advanced care planning process with them. And then to make sure that when they were hospitalized in the Gunderson Health System, those directives were there so that they knew what type of care people wanted. And they do offer consultation services to the public, but for a price. It's proprietary. Another project that is free is the Conversation Project. And this was done by Ellen Goodman, whose mother had Alzheimer's disease. And she was frustrated because she had never had these conversations with her mother. So when it got to her mother's end of life and she was making some of these difficult choices by herself, she didn't have the input of her mother and wanted other people, other families to have that chance to have the conversation before they were in her situation. And so if you go to this website, it has lots of resources for patients, for families, and for healthcare providers as well. And then moving sort of beyond the point of care and looking at research and policy, when we did our own research on advanced care planning, we started out surveying care managers within the area agencies on aging. And the interesting thing about this is this was back in 2009 when Congress was debating the Affordable Care Act, and they were going to put in a policy in there that Medicare would pay for advanced care planning conversations. And of course, people started saying, well, you want to pull the plug on grandma. No, we did not want to pull the plug on grandma. We just wanted to give grandma some choice in what type of care she received. And so it wasn't until 2016 that they actually allowed Medicare to pay for advanced care planning conversations to reimburse healthcare providers. After we talked to the interesting thing about the care managers at the Area Agency on Aging is because of that political atmosphere, some of them were reluctant to talk to their consumers about advanced care planning, but there were a lot of strong advocates as well for advanced care planning. Then we went on to family medicine physicians across Ohio, and we looked at some of their attitudes, what they were comfortable with and not comfortable with, and I'll talk a little bit more about the findings from that study in just a couple minutes. And then we went into skilled nursing facilities and talked to nurses and social workers about their attitudes and practices with advanced care planning. And then recently we've been looking at data from the health and retirement study out of the University of Michigan. And this is focused on patients because they have nice longitudinal data where they followed older adults over time. And then when the patient dies, they actually interview the family to see if that patient had someone had advanced directives or had conversations with family or healthcare providers, and whether those wishes were honored at the end of life. Ruth, do you want to talk about a little bit of your advocacy?
Sure. I have been doing a lot of advocacy and policy work depending on the level. So at the individual and sometimes committee work, it's been advocacy for advanced care planning and introducing it to people, advocating for patients who need it. We've offered some programs, some CE programs for licensed practical nurses and RNs on this topic. And then within my own organizational and professional association work with like health literacy and the American Academy of Nursing, I've been doing some policy work on this, particularly as I mentioned, I think in my intro, I've written that intro. I've developed a consensus statement with other members of an aging panel to introduce as a policy statement from the Academy. We'll see whether it's accepted or not, to start enabling advanced care planning at life's milestones so that it comes out as a policy statement for professional organization. Interestingly enough, Canada has it as part of their Choosing Wisely program, that it should be offered at landmark life changes. Kris?
Sure. So what we know, both from our own research and other researchers and people's experiences with advanced care planning, is that it's usually embedded in end-of-life care. So it's not routine. The Institute of Medicine recommends that you start when you get your driver's license, when you're 16 years old. And as life events happen and as your health changes, you go back to those conversations and figure out, how your preferences have changed over time. But it's often just treated as a simple checkbox, either yes, you have advanced directives, or no, you don't. And we know that one size does not fit all. That's why it's so important to have these ongoing conversations to really get into the nuances of what people want and don't want. And so it's sort of that interplay among individuals, families, the choices they make, the provider's knowledge about, what's futile treatment and what's not futile treatment, comfort measures, resources, and those organizational factors, such as the policies at that organization, what's available, what's not available. And COVID has made this even more important as the death rate has gone up during this past year. So when we talk to the family physicians, and this study was done a while ago, back in 2015, I think, we found that they were most confident in reassessing a shift in care goals and determining when those care goals there should be a shift in those care goals, and then discussing and negotiating those treatment goals with the patient. But they were not confident when it came to when their patients were hospitalized, whether that hospital would follow those wishes and honor the wishes of the patient. And they were also uncomfortable with finding enough time to talk to patients about advanced care planning. And that may have changed more recently now that Medicare is paying and reimbursing physicians, but at that point, they really didn't feel like they had enough time to do that. And then trying to determine who else should be in the room. This may have happened to some of you who talk to patients about advanced care planning. Are the people that are going to be making the decisions at the end of life actually in the room and helping to come up with some kind of plan for what kind of care to provide? So I want you all to think about what you're comfortable doing and what you're not comfortable doing in terms of advanced care planning. So, and we'll get to that more when we talk about the case as well. So in conclusion, advanced care planning is underused, not used as much as we would like it to be used, but those ongoing conversations can be so important throughout one's lifetime to figure out, as our goals change, figure out what types of care we most want and what types of care we don't want. There's a lot of misconceptions still about advanced care planning, that it should be done at the end of life, or that people are uncomfortable having these conversations. That we need to deal with in order to have more frequent conversations. Healthcare providers worry about ensuring that patients' preferences are honored if they do make those preferences known, and also finding time to hold those conversations. And then lastly, we just have a couple slides here with some more resources for you. The National Healthcare Decision Day website, Ohio Hospital Association's website with updated forms. The Bar Association has forms as well and information. CMS talks about the billing procedures and the payment for advanced care planning. National Institute of Aging has a website for patients. And then ARP also has a book that you can order that has all kinds of information that you can leave for your family. And in addition to advanced care planning decisions, you can also tell your family, what life insurance policies you have, where your will's located, who your lawyer is, and all of that information as well. So that's kind of a nice resource. So with that, I will stop sharing and we will go on to the case.
Kris, let me say one thing that just to add, that if you want the list of articles we've done, there's fairly extensive, as well as others in the group who've written on this. Let everybody know and we'll be glad to share it. And the other thing about the advanced care planning is this is a worldwide issue. And we've gotten a lot of uptake from that, a self-assessment, self-efficacy scale. And it's being translated into a number of languages. So there's just tons of work being done on this topic all around the world. We're not alone.
Thank you so much.